just an update with regards to a thing which is going to happen next year. That is, ACLS is going to come out with next year 2025 update. So don't know what that is going to be basically talking on, but the talks in the last conference were predominantly with something called as a CPR coach, which they did talk about but didn't emphasize much, and also on the chest compression fraction. So there is quite a lot of emphasis on that. And algorithm wise, I'm not sure if I don't think so there'll be much changes. Post resuscitation care and eCPR somewhere might come into play. So those are the things that we can look out for. I think CPR coach is somebody who, besides the team leader, probably make sure that the person does the right steps at the right time. Something like a scribe nurse who's scribing as well as does the CPR coach, or make sure that everything is happening. I am trying to get a presenter module. So ACLS, we presume that we know what is BLS, and out of hospital cardiac arrest and in hospital cardiac arrest, the chain of survival is important for you all to know. Activation, high quality CPR, defibrillation, advanced resuscitation, post cardiac arrest, and recovery remain a part of out of hospital cardiac arrest. For us, in hospital cardiac arrest, we talk about identification. That's why we've got a code blue, a metcall, and yellow zone. Activation of the code blue, that is the activation of the emergency response system. High quality CPR, which we'll revise. High quality CPR is push hard, 2 to 2.5 inches, push fast, 100, at least 100 to 120, avoid hyperventilation, minimize time for interruptions. So this minimize time for interruptions has been emphasized quite a lot in the last talk or in the last conference. You have to minimize the time to less than 10 seconds, then avoid hyperventilation and allow adequate chest recoil to happen, right? Then comes early defibrillation, post cardiac arrest care, very important, and then rehabilitation and recovery. So let's revise quickly. You have an unresponsive victim, you will shake and shout and check his responsiveness. And till today, every doctor I have noticed has always gone for this step, that is check a pulse. If you're having a person who is unresponsive and you've literally given him a good shout and tapped on his shoulder as well, then believe me, even though if he is sedated because of a post anesthesia effect or he's hypoglycemic, you all aren't going to be able to do things alone by yourself. So as per a protocol, it's not wrong that you check for a pulse, but please call for help before that. So activate. If you don't feel like activating the code, at least call for help. It's very important for this call for help step, which is there, which is getting missed out predominantly by all the doctors noted in all the BLS mock drills. All right. So we check for responsiveness, not responding, call for help. Then go to the patient, check the respiration and the pulse, all within 10 seconds. And then we start our BLS, which I was just saying is compression, airway breathing, high quality CPR. Continue doing this till the primary team arrives. This is what is expected for people. And when you reach there, you are supposed to be expected to take over from there. So an ACLS team generally can have a minimum of 4 to 5 people or a maximum of around 8 people, in which now this CPR coach is somebody who is important and is brought in. So you ensure when you reach there, whenever you reach there as a code leader, you all are code leaders. That's why you all are doing ACLS. So when you all reach there as a code leader, you will ensure that there is high quality CPR going on. So there cannot be a better emphasis on chest compression than this picture, which shows that at the time of compression, it's not immediately that you start with cerebral perfusion. It takes a few compressions for the cerebral blood perfusion to be achieved. And then look, when you stop the compression, how it takes another time for it. So the interruptions, if it is, we are saying 5 to 10 seconds, if it's longer than that, you anyways are taking much time to reach an adequate cerebral perfusion, you must ensure that your chest compressions are adequate and are not interrupted. So make sure that you've got high quality CPR going on. Take a brief targeted history, assign roles to everybody. To obviously, if an anesthesiologist is there, he's standing at the head end. The person from the ICU and the OR, or ICU and the ER is there. They're at the foot end to make sure that they run the role as a team leader. Then there are one nurse and there is one medicine person who is on call, who can probably help out in either the chest compressions or the defibrillation, and the ICU nurse can take over the IV line and the drugs. And then there is always a ward nurse also to be there along with you. Appropriate PPE prophylaxis exposure that needs to be prevented, and then you attach and analyze the rhythm. So at any given times when you reach there and the steps of at least chest compression, attaching the pads and bag mask ventilation have not been done, it's important that you all raise it to the scribing nurse and you all mention it in the code form that this much has not happened. So, it needs to be made sure that the ward is compliant with this. And then the rhythm is to be identified, and we run by the whole code, which says that if it is a shockable rhythm or a non-shockable rhythm. Shockable rhythms are basically ventricular fibrillations and pulseless ventricular tachycardias, and non-shockable rhythms are asystoles and PEAs. For a shockable rhythm, the first treatment is shock. For an asystole or a PEA, the first treatment is epinephrine. So an IV line with 1 milligram of epinephrine given every 3 to 5 minutes with a fluid bolus of 20 cc. Okay. So that should be the first answer that should come out of you all, and that should be the first step that should happen. All of this should happen within 2 to 3 minutes of reaching there. That's very important, that you are ensuring the chest compression is started in 30 seconds of identifying the victim to be unresponsive. Rhythm identification within probably 2 minutes of the team reaching there, ideally 2 minutes of starting the chest compression, and shock should be delivered within the first 3 to 5 minutes of, or even 3 minutes of starting CPR. So there are these important turnaround times which they are emphasizing on. So we checked the rhythm. It was a VT-VF. We shock. After you shock, you continue CPR for 2 minutes. In the meantime, get an IV IO access. Check the rhythm at 2 minutes. If it is a shockable rhythm, again shock. And here you give 1 milligram of epinephrine every 3 to 5 minutes. Consider then an early placement of an advanced airway. If this is going to be requiring more than 2 shocks and it is going downhill, you should consider placing an advanced airway. After that, when you are planning to place an advanced airway, don't stop the chest compressions. Don't stop everything. Please continue chest compressions. Get your equipment ready. If your equipment is going to take time, that doesn't mean the chest compression and the shock and the rhythm identification or the epinephrine gets stopped. So every 2 minutes, check the rhythm. If it's a shockable rhythm, shock the patient and give epinephrine if it is within 3 to 5 minutes, followed by a fluid bolus. Subsequently, if you've landed up having 2 subsequent shocks given, and now you're giving the third shock, this probably moves towards a refractory ventricular fibrillation. So you must think of starting him on amiodarone. This amiodarone is generally 300 milligrams as a bolus, or you can use lignocaine, which is around 2 milligrams per kg of body weight, followed by an infusion. On the same side, if there is a patient who has an asystole and a PEA, you confirm that all the leads and everything is attached and this is a true flat line. By the time you've already given the order of giving 1 milligram of epinephrine, followed by a 20 cc saline push, and you watch the rhythm within the next 2 minutes. Next 2 minutes, there is again a PEA asystole. You then think of sending a blood gas and trying to rule out for the 5 H's and the 5 T's. In the meantime, here again, think of placing an advanced airway if things are getting delayed, or if you think that you're, this is getting longer, then you should be thinking of going ahead for placing an advanced airway. If there are no signs of return to circulation and you've got all the 5 H's, five T's, then you probably need to ensure that you've escalated to your senior and made sure that there isn't any scope of anything else like any CPR or something. Now, again, a recapitulation about the little theory. Besides the push hard, push fast, minimizing interruptions, avoiding hyperventilation, and having a ratio of 30:2, which is maintained for all adults, pediatrics, and children in a single rescuer. And if it is a child, when there are two rescuers, it is 15:2. So we can also do something called as a quantitative capnography. If the patient is in the ICU, get a ETCO2 and see if you're able to look at the ETCO2 waveforms, or an arterial line is there. Placement of an advanced airway may not be only restricted to the use of an endotracheal tube. If you are unhappy and you're not sure, an LMA also can be used at this present time to help to tide over the crisis. The type of defibrillators that are available with us are biphasic defibrillators, and they maximum shock to 200. So you need to use 200 joules for these patients to get defibrillated. Steps of defibrillation and everything is there in the next slides in the videos. So once you get a return of spontaneous circulation, that is when you get an abrupt rise of ETCO2 or a diastolic blood pressure, or you get a organized perfusing rhythm. That's the time when you start looking at the patient from head to toe. All right. The 5 H's and the 5 T's. Hypoxia, hypovolemia, hydrogen ions, that is acidosis, which you will get in an ABG. Hypoxia you will get in an ABG. Hypovolemia you will get from the history or the clinical findings. Hyperkalemia, again ABG. Hypothermia, but that's but obvious. I mean, you'll get to know a history, or you'll understand it from the patient's temperature. With the tension pneumothorax, very difficult to be missed out, and very sometimes difficult to be diagnosed in an ER. So generally, if the patient has had some procedure just done, or some tapping done, so then you need to keep that in mind. Cardiac tamponade, again, when they come out after again a procedure, or if they've had a myocardial infarction. Toxins, especially when they are in the ER and you're not sure of what is happening with them, and there could be a possibility of any intoxications. Thrombosis of the coronary and the pulmonary, we all know that is again from the history or a diagnosis which is of exclusion. So we'll try to run through this video. Let's see. All right. Hopefully this is working.
Products are formed for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use personal protective equipment, such as gloves. The following information represents American Heart Association guidelines and best practices for measuring and improving the basic life support skills of the teams you work with. The guidelines recommend that healthcare providers tailor the sequence of rescue actions based upon the presumed etiology of the arrest. ACLS providers functioning within a high-performance team can choose the optimal approach for minimizing interruptions in chest compressions.
You all can hear, right? Anybody, somebody?
Yes, sir, we can hear you, Prof.
Thank you, Prajakta.
There are different protocols to maximize chest compression fraction and high-quality CPR. Performance teams are essential to successful resuscitation efforts and can translate to improved survival for patients in cardiac arrest. Performance teams effectively incorporate timing, quality, coordination, and administration of the appropriate procedures during a cardiac arrest. In addition, these teams clearly identify their overall purpose and goals. They are aware of the skills each member possesses and not only understand each team member's motivation, they know their strengths and weaknesses. High-performance teams also incorporate effective conflict resolution and communication skills. And last but not least, high-performance teams continually measure their performance, evaluate the data, look for ways to improve performance, and then implement those learnings. One of the measures of a high-performance team is the ability to achieve specific performance metrics in the high chest compression fracture, or CCF. CCF is the amount of time spent doing high-quality chest compressions during a cardiac arrest event. You can only achieve a high CCF by eliminating pauses during high-quality CPR. The resuscitation outcomes consultant, or ROC, showed that a 10% increase in CCF is roughly equal to an 11% increase in survival. Pauses typically occur during intubation, rhythm analysis, pulse checks, compressor switches, and defibrillation. We'll address some best practices for eliminating pauses in some of these areas, but you'll also need to measure high-quality CPR metrics at your own place of practice to identify other areas where pauses exist. You can't improve what you don't measure. Over the chest and be prepared to resume compression. 4,000 compressions at the end of each 2-minute cycle. High-performance teams check for a pulse replacement. Charge to the CPR still. CPR. However, the feedback device isn't permanent. Or defibrillator doesn't have a mechanism. Performance teams also practice good communication skills and adhere to the key elements of effective team dynamics. These elements help teams work together in the most efficient way possible. The American Heart Association has grouped the elements of team dynamics into 3 categories: roles, what to communicate, to be immediately established by the player on the team. When all team members know their roles and responsibilities during a resuscitation attack, team functions smoothly. Team should know his or her limitations. Team members should ask for assistance and advice early, not when the situation deteriorates. I'm going to that are incorrect or inappropriate. It's important to be careful. Correct colleague. Some observations from the team. Communication. Process of verifying that the message sent was received as intended. It also verifies that any assigned tasks have been completed. In addition to using closed-loop communication, teams should use clear messaging. Concise, clear language helps prevent misunderstandings. Teams that work together frequently can create terms or phrases that have specific meaning for them to ensure clarity among members. 145. Let's go ahead and try that. Are you pulses with CPR? Good, I wrote pulses with CPR still. Finally, teams need to communicate with respect. Speak to each other in a professional manner, regardless of scope of practice or expertise. Resuscitation events, stress, and emotions can run high. Understand that this is the nature of CPR. Remember the lives they're trying to save. Not only is it important to know what to do during a cardiac arrest, but it's just as important to know how to work together as a team during an event. Debriefing as a team is an important component of every resuscitation attempt. Safety briefing during and after an attempt helps individual team members perform better, but it may also bring system strengths and efficiencies to light. Implementation of debriefing programs may even improve patient survival after cardiac arrest. It's not enough to know what to do or even how to do it. To obtain the best results, your team must perform both the what and the how. Brief the team, set goals to improve, and practice more. On the team can Once I put down the answers, so we can take a look at your eye rhythm. Way of seeing Protective 92. Please, it's on well to the nasal cleaning. What's going on? Is something wrong? Yeah, I don't know. Oh. More occupations. Really, if you'd like to stay with the family waiting room. Is not the end of the cardiac arrest protocol. Performance team should continue to maintain an acute sense of urgency. Patients are still in a toxic state, and the possibility of another arrest is extremely likely. One of the key actions to take is targeted temperature management. It's the only intervention that has been shown to improve neurologic recovery after cardiac arrest in ROS. The resuscitation team should consider inducing targeted temperature management for any patient who remains comatose after ROS. The AHA recommends cooling to a target temperature of 32 to 36 degrees Celsius for at least 24 hours. More scientific studies show that survival rates improve significantly with a comprehensive system of post-cardiac arrest care. It's important to know your local system's plan for the management of post-cardiac arrest patients. Combining your knowledge of essential arrest skills with timing, quality administration, and coordination through effective team dynamics can give your team a better chance of success with every resuscitation attempt.
All right. Can you hear me now?
Yes, sir.
So we can hear you, but there was disturbance when the video was going on. So,
There was disturbance.
yeah, disturbance in the sense the voice was not coming in between.
Okay. For the benefit of everybody, I'm not going to play the video again, obviously, but I can run through the algorithm again. That's the only thing I can tell you all. So, what the algorithm was trying to say was something called as a hover. What is hover? When you are doing high performance teamwork for like you do high quality CPR, when you're doing high quality ACLS, you try to minimize your time of compression interruptions to your compressions. So the person who's doing chest compression at the count of 25, 26, 27, 28, 29, 30 does not leave this position. He just goes above the patient and waits for the rhythm to get analyzed. If the rhythm says it's a shockable rhythm, the pads are already attached. If the pads are not attached, you please continue CPR, attach the pads, you can charge, and after you charge, you can say, I'm clear, you're clear, we're all clear. You stop the compression, obviously, cleared everybody, and then discharge. And the most important step is resume CPR. So that's one. Second is the use of a feedback device. Now, we've been trying to struggle by asking people to use a feedback device. We have a defibrillator, which unfortunately is only one in the hospital, which gives you the answer of the feedback device. So we are trying to procure devices or defibrillators which will speak on itself with regards to your depth and rate of compressions. This feedback device is generally placed on the chest of the patient with a sticky. You do chest compressions on it, and it either shows you visually your depth, like when you all are doing CPR on a mannequin, you'll see in our hospital mannequins, there's a green color light on his left shoulder. Similarly, that CPR device shows you a green color when the depth is adequate, and it also changes its color if your rate is inadequate, if it's too fast or it's too slow. So you got to optimize your chest compressions according to that light. So this pad or this device is available as two different things. It comes integrated with a AED pad, which we're trying to get, but unfortunately it works with a specific company's AED. or it works as a standalone piece. But it's important for you all to know, since you're listening about ACLS, might as well get some more knowledge. So these pads are also recommended. So first was hover over the chest, don't leave your position. Second was have these feedback devices. Third was they generally keep the in a VF arrest, they generally keep the defibrillator charged. So what that means is when you are at the 2-minute cycle and you are going to be at 1 minute 45 seconds, at that time they keep the defibrillator charged and they identify the rhythm. If these are the new guidelines, okay, these are things that might just come up, that if you have at 145 seconds you have charged the defibrillator and at 2 minutes you stop compression and you identify a shockable rhythm, you don't have to wait and charge and then discharge. You've already got a charged defibrillator. You can then just say, I'm clear, you're clear, everyone's clear, and deliver the shock. So that was another method which is upcoming for decreasing your time of interruptions. Where else do you interrupt? When you check a pulse. So it's important for you all to check a pulse and call out 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you can do that. You can do that. And you should generally try and check a pulse and keep it stipulated within 5 to 10 seconds. So that is the third point, that the interruptions need to be minimized. Another fourth way in which you can minimize your interruptions is intubation. So when you are planning to intubate, please get everything ready. Continue the compressions till that time. Do an oral suction, put in the laryngoscope, and the moment you are going to be visualizing the cords, have a tube already loaded with a stillet. Don't wait for trying to do it without a stillet. So keep the stylet loaded. If you think that this guy is going to be a hefty bull neck, short neck, difficult intubation, believe me, it's better to have a bougie in your hand and someone with the, so plan your intubation so that your time of intubation is minimized. The moment you intubate, cuff inflate and check. We don't have an ETCO2 in our wards or in our AED carts. We are in the process of procuring new defibrillators which will have an inbuilt AED. Inbuilt ETCO2. So we'll try and do that. It's just going to be a matter of time, but till that time, it's important that we note that we need to minimize our times for interruptions. So hover, feedback device, pre-charged AEDs, pulse check, all within 10 seconds, and continue to ensure high quality CPR. If you're going to get tired, have someone already ready that, look, I'm going to get tired, you need your help. So we run through the whole algorithm once again. You have an unresponsive victim. I'm going to do it with BLS and then with ACLS, and then we'll stop. We'll do the rhythms in the next class, which I will take on Monday. So you've had a person who's unresponsive. You reach the scene is safe. You tapped on his shoulder. He didn't respond. You shook him and you asked him, sir, are you okay? You've done it twice, thrice to confirm that he's unresponsive. There's no response. Call for help. Check the pulse and the respiration in 5 to 10 seconds. Immediately start chest compressions. You are the second rescuer who comes in. Please walk into the room with the crash cart. Place it opposite the person who's giving CPR. Get the pads out. The pads are kept on the cart on the left-hand side, on one side. You take out the pads, attach it, make sure that it's attached to the defibrillator. Continue the chest compressions as you're attaching the pads. Once you attach the pads and you've put the defibrillator, then you go to steps of defibrillator. So the steps of defibrillation are power on. You put the AED on. Power on. You've already analyzed it, so you can choose in the machine that we've got. You have to probably choose the word pads. So there's lead 1, lead 2, lead 3, and then there is pads. So you choose that, analyze the rhythm. It's a shockable rhythm, then you will charge. Now, you charge to around 200 joules. As you're charging and you're doing all of this, ensure that you're continued with your chest compressions, and then you will clear everyone and discharge. And immediately after discharging, you will resume CPR. Now, as you do that, another rescuer can already come and take an IV line. As you take an IV line, if you're able to get some blood samples, obviously IV lines are going to be cubital, large bore IV lines. Blood samples are taken. You can even send it for a VBG at dose sugar. Then you immediately continue high quality CPR, push hard, push fast, push hard 2 to 2.5 inches, push fast 100 to 120, avoid hyperventilation, minimize interruptions, allow adequate chest recoil, and then you go towards yeah, I think I said all 5 of them, sorry. So yeah, avoid hyperventilation. Then as you're doing that, you try and identify the rhythm. The rhythm is a shockable rhythm. The answer is shockable rhythm. The answer is shock. Shock the patient, start CPR, wait for 2 minutes, reanalyze the rhythm. If it's a shockable rhythm, you can shock. Now wait, as you're waiting, you don't need to wait. If you've got a dose of adrenaline with you, you can always say that, look, I've got an IV line in place, I've given a shock and started CPR. There is no harm if you give a dose of adrenaline a bit earlier. Nobody is going to catch you and tell you. But remember, in a ventricular fibrillation, what is going to convert a patient is early defibrillation. So if you are going to be saying, I have an IV line and let me just put in adrenaline first, it will help to bring out the patient. No, it is a change of rhythm that will help it get the patient out rather than the adrenaline. So if you've given one shock and now you've got an IV line and now you're continued CPR, you can give 1 milligram of adrenaline followed by 20 cc of saline as a bolus every 3 to 5 minutes. You've got 2 shocks delivered, you've given an adrenaline, probably you've come to a point where these are getting into a refractory ventricular fibrillation. At this time, you must consider using 300 milligrams of amiodarone as a bolus, and then try and look out for the 5Hs and the 5Ts. In the meantime, since you've given amiodarone and you've now had a situation where the patient is not reversing back or you're not getting an ROSC, please consider placement of an advanced airway. As you are preparing to place for an advanced airway, continue high quality CPR. Let's say you've got a non-shockable rhythm, then the first answer is you give him adrenaline, continue CPR, and check after every 2 minutes what is the rhythm. If it remains asystole PEA, place an advanced airway, get the AGT and the labs by doing a blood gas, and then take it from there with regards to what the patient is. I'm going to stop and ask you, do you all have any doubts beyond this? No answer means no doubts. All right, as what I had said is what I have shown over here. Just one point to remember, when we are avoid this hyperventilation bit, because what is happening is you tend to just keep on excessively ventilating, and that's not good for a patient. So one breath every 6 seconds, all right, in a cardiac arrest. Is that very clear? All right. Let's do this.
Algorithm is the most important algorithm to know of adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including confirmed shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their life, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt. Treatment then branches into two pathways, one for shockable rhythms, which include VF and pulseless VT, and a pathway for non-shockable rhythms, systole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. 2 minutes, conduct the rhythm check. For participants or pulseless VT, give another shot and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shot has been delivered. Keep epinephrine administration every 3 to 4 minutes is mid-range, which corresponds to every other rhythm tune. During resuscitation, the vasoconstriction increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. 2 minutes of CPR. Being careful to minimize interruptions in chest. The rhythm check reveals a shockable rhythm to deliver another shock. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone or lidocaine, antiarrhythmic agents that have been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha adrenergic and beta adrenergic blocking properties. It also blocks the action of hormones that speed up the heart rate. The overall effect is to slow the heart. It lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. Lidocaine suppresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. Amiodarone or lidocaine, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5. Work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you are unable to achieve ROSC in a reasonable amount of time, consider the appropriateness of continuing resuscitation efforts. If you encounter non-shockable rhythms at step 4 or 6, and there are no signs of ROSC, look at 10 or 11 on the systole PEA pathway. And the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes, or every 4 minutes is mid-range, which corresponds to every other rhythm. Or 7. The rhythm is non-shockable. Continue CPR for 2 more minutes. Treat reversible causes if these have been determined. If there are no signs of ROSC, move on to post-cardiac arrest care algorithm. Cardiac arrest algorithm. High-quality CPR performed continuously, but also CPR quality is monitored consistently.
All right. And then the last thing that is on ROSC. Do you have any questions till now? I'm sure nobody does. All right. you all will have to, as per the request of Homa, to make these attendance counted. I think your names are already there in the chat box. If not, put in your names in the chat box. I don't know if Prajakta can take a screenshot of that chat box. It's important that your names get captured. B, you'll also need to go on to the R University and do the ACLS read and assessment, and then do the assessment sheet, that is the test. Okay, it's mandatory for all of us, especially from the ICU, from the ER and the OR. Okay, and for the doctors and the nurses. So if it's not there, then y'all will take this class, not me. Okay, so now we come to the last bit of the lecture, that is ROSC. ROSC is return of spontaneous circulation. Once you've got it, you are confirming it with an airway capnogram, which is showing an abrupt rise in the EtCO2. You're seeing the patient breathing, obviously, and you're also seeing a good pulse and some blood pressure. So these are all signs of ROSC. If the patient, you start looking at the patient once you get an organized perfusing rhythm. So ROSC is defined as when you get an organized perfusing rhythm. If there is an organized perfusing rhythm, which is P followed by a QRS or a QRS complex alone, you can check the pulse. So you don't need to check pulse in this whole algorithm. I've never said to check the pulse. I've always said at 2 minutes to check the rhythm. Please note another common mistake done by everybody at the mock code blue. Everybody goes to check the pulse. There is no role of checking of the pulse unless you have a organized perfusing rhythm defined as P followed by a QRS or a QRS, QRS, QRS. All right. So that's important for you all to know. If you get an ROSC, you start from head to toe, you wake the patient up and you see whether he's responding. You ensure that the saturations are maintained above 95, whether that's required with a mask, with an airway, LMA got to change to an ET tube and put the patient on the ventilator. You look at the pulse, you maintain the pulse rate. You look at the blood pressure and you maintain the blood pressure, either by giving fluids or by starting vasopressors. And then if the patient has not responded, you've secured the airway, then you do a targeted temperature management, which has shown to improve outcomes, especially in in-hospital cardiac arrest, especially with ventricular fibrillations or ventricular tachycardias. When you do that, you got to maintain a continuous core temperature, that is a rectal temperature between 32 to 35, have normoxia, normocapnia, euvolumia, euglycemia, and if it is possible to do a continuous EEG monitoring with lung protected ventilation. This whole thing, what I have said, is called as ROSC care. Obviously, you've done an ECG. ECG, the patient turned out to have ST elevations or STT changes, then you must consider going for an primary angioplasty or a PAMI. All right. I'm sure there aren't any questions, so I don't think so. This is just for people's knowledge if you all want to know about neuroprognostication. Otherwise, I think we can wrap up. I'm waiting for any questions, and I think we can meet on Monday and we'll finish the second session. No questions are good. You all will have to put in your names. I don't know what is with the chat box, but ensure that everybody's names or the attendance. So as whoever has left would probably not be marked attended. So that's good. We've got a chat history of attending and not attending. What is this H? Who has attended as joint and who has left? Mr. Who might have to identify yourself. Anyways, no questions. Thank you, everybody.